Assalamu alaikum. I am Dr. Abdul Rehman, and today the topic of my presentation is Tinea Troubles, Diagnostic and Pathological Insights into Dermatophytosis. So, dermatophytosis, also known as tinea or ringworm, it is an extremely common skin and other superficial infections, and the majority of people have suffered from it at some point in their life, whether it is a nail infection, hair infection, or athlete's foot. So, it is a very common infection and often neglected in such settings. So I will start with two simple case descriptions, and then I will follow through with their presentation, diagnosis, and management. So first case, it is an 8-year-old boy who presented with 1 month history of itchy and scaly patches on his arm and back. And there were no other systemic signs except these patchy lesions. And physical examination revealed multiple oval and raised lesions which were clear in the center. And child also had alopecia of the scalp. And the child lived in a rural area. And he was actively involved in the care of several animals on his farms. And the animals included cattle, dogs, horses, and cats that were owned by the family. So these are the pictures of the lesions over his arm and the body. As you can see, these are red scaly lesions in a circular pattern, and there is slight central clearing in the lesions. So for diagnostic purposes, skin scraping samples were taken and 10% potassium hydroxide preparations were made. And on the KOH preparation, you can see slender septate hyphae. So these are indicate fungal hyphae, and these are indicative of a dermatophyte infection. So on the fungal culture, orange yellow to cottony colonies of fungus were obtained after 10 days of incubation on selective media containing cyclohexamide. So a lactophenol cotton blue preparation of the fungal colonies were made, and on the lactophenol cotton blue preparation, thick walled and spindle shaped macroconidia with 5 to 15 cells were seen. So this large feature, this is a spindle shaped object is the macroconidia, and there are 5 to 15 segmentations, and the small pear-shaped structures seen here and here, these are the microconidia, single-celled spores of the fungus. So the gross morphology and the lactophenol preparation features are suggestive of Microsporum canis, that is a dermatophyte fungus species, and that diagnosis is Tinea corporis, that is ringworm infection of the body. So for the Tinea corporis, the specific treatment is topical terbinafine for 1 to 2 weeks of duration. And as this is a zoophilic fungus that is transmitted from animals to the humans, there is need for evaluation and treatment of affected animals. And in this case, for Microsporum canis, the particular hosts are domestic dogs and cats. So there is a second case, and it is a 52-year-old diabetic male who presented with thickened yellow and brittle toenails for the last 6 months. On the examination, yellow to brown and thickened and crumbly toenails were present, along with subungual debris. So the nail clippings sample was taken, and 10% potassium hydroxide preparation was made. And again, septate fungal elements were seen on the potassium hydroxide preparation. And on fungal culture, growth of a flat mold with sweet-like texture and red diffusible pigment was obtained after 2 weeks of incubation. So this is the on the top is the picture of the mold, which has a sweet-like texture, and red diffusible pigment is present in the media. And on lactophenol preparation, many microconidia in a bird on a fence like pattern are seen, and macroconidia are absent in this case. And biochemical tests were also set, and this isolate was urease negative after 7 days, and hair perforation test was applied, and it was also negative. So the diagnosis in this case is distal subungual onychomycosis, also known as Tinea unguum, that is infection of the nails. And the fungus was identified as Trichophyton rubrum based on the gross morphology and lactophenol cotton preparation features. So the treatment for Tinea unguum or the onychomycosis is oral therapy with terbinafine for 12 weeks. In the case of Tinea corporis, only 1 to 2 weeks of topical antifungals is recommended, whereas in the case of nail infection, oral therapy is recommended, and for that is for 12 weeks. And along with food hygiene advice and improve diabetes control. Now, coming to the topic of cutaneous mycosis, also known as dermatophytosis, these are the fungal infections that only involve the stratum corneal or deeper layers of the epidermis. And the fungal organisms that cause these diseases are called dermatophytes. So overall, there are about 9 genera of fungus that can cause these diseases in humans and animals. But for humans, only 3 genera are significant, including Microsporum, Trichophyton, and Epidermophyton. And these genera are characterized by their anatomic site specificity. And this table describes their anatomic and specificity and geographic distribution. So dermatophytes can be either anthrophilic, zoophilic, or geophilic. Anthrophilic fungi are only present in the humans. There are no animal sources or environmental reservoirs. And these include Trichophyton rubrum, Trichophyton tonsurans, and Epidermophyton flocosum. And these fungi cause a chronic and mild infections, and often there is no significant inflammatory reactions. For zoophilic fungi, there is a significant animal reservoir, and these include Microsporum canis that has a reservoir in dogs and cats. Trichophyton verrucosum is present in cattle and sheep and other ungulates. And Trichophyton mentagrophytes variant mentagrophytes is present in monkeys and other small animals. And these infections are acquired after direct contact with the infected animals. And these have more severe clinical course with marked inflammatory reactions. Then the last group is geophilic fungi. And these are present in environment including soils and plants. And these are acquired after environmental trauma or other penetrating injuries acquired in the environment. And these infections are also severely inflammatory and usually acquired after soil exposure. So the 3 most important dermatophyte genera in the for humans include Trichophyton, which can cause Trichophyton species can cause infections of skin, nail, and hair. These can involve any of the 3 superficial components. So, and Microsporum, it can infect scalp or skin. Microsporum species usually do not infect the nails. And Epidermophyton, it only includes a single species. And it can infect either the skin of groin or nails. So Epidermophyton usually does not infect the hair, whereas Microsporum species do not infect nails. So coming to the transmission, and usually the transmission is happens when fungal spores penetrate through intact skin or burns or other scars. And the fungal spores can persist in the environment and homes for months to years. So the transmission can be either direct or indirect. Direct transmission occurs through directly contact with an infected animal, individual, or environment. Whereas in indirect transmission, there is contact with contaminated surfaces, objects such as hairbrushes, towels, mats, and carpets, etc. So, if one person is infected in a home and the people live in a close proximity and share personal use equipment, other members of the household can frequently get infected as well. And in such environments, shared wet surfaces such as showers, pools, balconies, bathtubs, these are the major sources of spread. Whereas in community settings, uh, like gyms, schools, and mosques, etc., mats are frequently the source of infection, such as in public pools, sports facilities, hotels, and mosques. So there are certain predisposing conditions to get an dermatophyte infection. Not all those individuals who acquire a fungal spore will go on to develop clinical infections. So these predisposing conditions include poor socio-economic conditions, such as living in a closed space, hot and humid climate, especially in tropical regions, increased perspiration and occlusive clothing, such as in athletes and wrestlers, etc., and can lead to athlete's foot and other rashes. Chronic venous insufficiency, it is a major risk factor for onychomycosis. Diabetes mellitus, prolonged antibiotics and corticosteroid usage, HIV, and other immunosuppressive therapies. So the first step of the pathogenesis is adherence of the fungal spores to the stratum corneum. That is followed by invasion of the fungi, and that is mediated by certain fungal keratinases, lipases, and sulfite efflux pumps. And after invasion, the fungi evade the immune response, and that is followed by inflammation mediated by Th1 and Th17 cells. And once an infection is established, it can be chronic or self-limited. So I have described Tinea corporis and onychomycosis tinea angum in the case the two cases are presented. The other major presentation is the Tinea capitis, that is infection of the scalp or hair shafts. It often presents as a circular bald patch with short hair stubs or broken hair within the hair follicles. And the infection of the hair can either be endothrix, in which fungus is present within the hair shaft, or it can be an ectothrix, where the fungi does not penetrate within the hair shaft, but it is only present outside of the hair surface here. Severe form of tinea capitis is the chirion, which you can see in the bottom picture, where the raised yellow boggy area is present, and it is often misdiagnosed as a fungal bacterial abscess. So, a special feature of tinea capitis is dermatological examination by Woodland. Certain species of microsporum, they produce a characteristic fluorescence pattern, which can give a clue to the diagnosis on a simple examination. Other common presentation include tinea pedis or athlete's foot. It can involve the interdigital spaces or lateral aspect of the foot as well if the condition is left untreated. And it presents as acute itching and red vesicular rash. And second, other common presentation is tinea cruris, that is the infection of intertritiginous area of the groin, and it also presents as a pruritic erythematous scaling lesion. So these conditions I have described, these are the common presentations. There are also some unusual and rare presentations. First is Mejosis granuloma. It is a localized form of fungal folliculitis that is characterized by deep pustular plaques and with a pink scaly area with pustules or papules at the periphery. So at the top pictures, you can see a form of folliculitis with scaly areas and pustules, and it often presents as a bacterial folliculitis, and the diagnosis can be missed or delayed. And then there is a dermatophyte.id reaction that describes skin eruption that occurs as a reaction to the fungal infections. So the rash you see in the picture is not actually due to the fungal infection itself. The person might be suffering from fungal infection at other sites such as foot or nail, and this rash is due to a hypersensitivity reaction, specifically type 4 delayed hypersensitivity reaction to the fungal antigens. Lastly, there is tinea incognito. That is an atypical presentation of dermatophyte infection due to use of prolonged topical corticosteroids or other immunosuppressive therapy. So if an dermatophyte infection is not properly diagnosed and patient is only prescribed topical steroids, the typical presentation is often masked, and the clinical features may become varied and lead to misdiagnosis and prolonged inappropriate treatments. So why the rapid and proper diagnosis is needed? Because a host of other skin conditions can mimic these dermatophyte infections. And for tinea capitis, that is fungal infection of the scalp, alopecia areata, seborrheic dermatitis, psoriasis, and trichotillomania all can mimic fungal infections. So on the bottom right picture, you can see a seborrheic dermatitis of the hair. So on a simple overlook, it can mimic as a fungal infection. Then for tinea corporis, nummular or discoid eczema, it physically is almost similar to the tinea corporis. So you can see the round scaly lesions, and these are almost similar in appearance to the rash of tinea corporis. So tinea cruris, that is the infection of the groin. Candidal infections also appear similarly, and then psoriasis and erythrasma, that is a superficial infection by Corynebacterium manutussimum. They also present similarly. So the rash or red pinkish moist lesion in the axilla, that is actually erythrasma caused by Corynebacterium manutussimum. So that is treated with topical or oral antibiotics, not antifungals. And psoriatic nail dystrophy, as you can see in the bottom picture, is clinically similar to the onychomycotic lesions. So coming to the diagnosis, specimen collection is very important part for the diagnosis, as quality of the specimen plays an important role. And if the patient has already started topical or oral antifungals, the specimen will be negative after a few days of therapy, and it can lead to false negative results. So for skin lesions, skin scraping sample should be taken, and it should be taken from the leading edge of the rash after skin has been cleaned and disinfected with alcohol. For Tinea capitis, hair infection, hair should be pulled from the roots, and those hairs should be chosen that either fluoresce under a wood's lamp, or if fluorescence is not present, those hairs should be chosen that are either broken or scaly. And for nails, clippings or skin from under the nail can be scraped for lesions for diagnosis. And the specimens should be transported in a sterile container or a black paper envelope. The first and the simple diagnostic methodology is the microscopy, which can either be direct 10% potassium hydroxide preparation, and that can be then examined under a routine light microscope. So you can see on the bottom the features of dermatophyte fungal elements. These appear as thin septate hyphae with uh, branching at almost 90 degrees. And then potassium hydroxide preparation can be modified with calcofluor white stain, and that has an improved sensitivity, but it requires fluorescent microscopy. So both of these methods have varying sensitivity and specificity, and that depends on the quality of specimen and the expertise of the person performing this. And various studies have described sensitivity from 60 to 90%. However, they are slow, laborious, and costly, often requiring 1 to 2 weeks for fungal growth. So the media used can be either non-selective fungal media such as savar or dextrose agar and potato dextrose agar, and then there can be selective media because these fungi are slow growing. So the plates can get contaminated with other saprobic fungi and bacteria. That's why we need a specific and selective media. So chloramphenicol that inhibits the growth of yeast and saprobic fungi is added to these media, and chloramphenicol for to inhibit bacterial growth, and cyclohexamide to inhibit fungal growth is added. And these media also contain phenol red indicator. And as you can see in the picture, the media surrounding the fungus has turned red. So when the media turns red, indicates that fungal growth is started. Once fungal growth is obtained, next step is to prepare a lactophenol cotton blue preparation. It is also a simple and quick method to evaluate the morphological features of the fungus. So the lactophenol cotton blue dye, it contains three components: lactic acid, phenol, and cotton blue dye. So the phenol component that kills and inactivates the fungi, and it inhibits the spread of fungi to the user. And lactic acid preserves fungal elements, and the cotton blue imparts blue dye to the fungal hyphae and spores. So specific features of the fungi such as sporulation pattern, size of microconidia, macroconidia, and the arrangement of this conidia. These are specific to each species, and species identification can be made. However, as closely related species, they cannot be diagnosed solely on the basis of lactophenol cotton blue preparations, and other biochemical tests or molecular tests or MALDI-TOF is often required. So the biochemical test we use as urease, like Trichophyton rubrum is urease negative, while most of the other Trichophyton species are urease positive after 7 days. Then hair perforation test, that in which fungi is incubated along with hair, and certain fungal species they will actually penetrate into the hair, whereas Trichophyton rubrum will not penetrate. And then there are certain species can be differentiated by nutritional requirements for certain vitamins. Then bromocresol, purple milk solid glucose agar, again, it is also a selective medium in which certain species produce a purple color or certain clearing. And rice grain test is also a similar test. Then MALDI-TOF, it is a proteomic based identification method, which most of the clinically significant fungal species can be identified on this MALDI-TOF analysis. Lastly, PCR of the internal transcript space region, ITS region of the ribosomal DNA. This is a DNA segment that is preserved in the fungal species, and sequencing of this region can be used for exact species identification. Once diagnosis has been properly diagnosed, whether on clinical features or laboratory diagnosis, so the treatment is then started. The treatment can be given with usually treatment is recommended topically only. However, for onychomycosis and infection of the scalp, oral treatment is recommended. The topical agents can be either azoles, allylamines like terbinafine, benzynamines, and cyclopirox. Oral treatment can be oral terbinafine, itraconazole, and fluconazole. And griseofulvin is also used for extensive or refractive cutaneous infections. So, ketoconazole is also an antifungal agent, which was previously used for given orally to treat dermatophyte infections. However, currently it is not recommended because there are severe risk of liver injury, adrenal insufficiency, and drug interactions. So these are specific treatment recommendations based on the site of the lesion. For tinea unguum or onychomycosis, uh, treatment is only oral and it is recommended for 6 weeks if only fingernails are infected, or if toenails are infected. Oral treatment with terbinafine is recommended for 12 weeks. And even after such prolonged treatment of 12 weeks, only it is only effective in approximately 79% of the cases. And other treatment can be oral itraconazole for 3 months, which is effective in 60 to 70% of the cases. And the alternate therapy in onychomycosis is oral fluconazole for 3 to 6 months, and it is only effective in 50% of the cases. For tinea capitis, oral terbinafine for 2 to 4 months is recommended. For other fungal infections, only topical therapy is sufficient. For tinea corporis and cruris, 1 week treatment with 1% terbinafine topically is effective. For tinea pedis, 2 week therapy with 1% topical terbinafine or topical butanafine is recommended. However, in cases of chronic and widespread or non-responsive tinea infections, those that do not cure with standard topical treatment, terbinafine orally can be taken for 4 to 6 months. Now coming to the epidemiological aspect of these infections, these are extremely common, and of the 650 million fungal infections that occur over the world per year, roughly half of the fungal infections are caused by dermatophytes. And in some countries, more than 25% of the school children are infected with scalp ringworm, that is Tinea capitis. And estimated 3% of the global population is infected with Tinea pedis, and almost 5.5% of the global population is affected with onychomycotic lesions. So currently, the Trichophyton rubrum is the most common species that is isolated in these cases. However, recent trends have shown that Trichophyton mentagrophyte is starting to become the most common isolate, especially in our setup in Pakistan and India as well. So in recent year, there has been a global concern about antifungal therapy failure and the emergence of antifungal resistance. So treatment-resistant dermatophytosis caused by Trichophyton rubrum, mentagrophytes, and Rotini have recently emerged. And this phenomenon is spreading, in particularly important in endemic areas such as India. In studies recently done in India, very high resistance rates were found against terbinafine in Trichophyton interdigitale. 76% of Trichophyton interdigitale isolates were resistant to this terbinafine, and almost 68% of Trichophyton intertini were resistant. In a similar study done in Iran, 33% of the Trichophyton interdigitale isolates were resistant to terbinafine. And this resistance has also been described in Germany. And for resistant against azoles has also been described in India, Iran, and Germany. So this table describes the results of a study done in Jinnah Hospital, Karachi. Of the 61 dermatophyte isolate in skin and other superficial samples, 12% were resistant to fluconazole, and 19.7% were resistant to fluconazole, and 11.5% of the isolates were resistant to terbinafine. And as you can see, Trichophyton mentagrophyte isolates were resistant to fluconazole in 38.9% of the cases, and Trichophyton rubrum, of the two isolates, Trichophyton rubrums are isolated, 50% were resistant to fluconazole. So coming to this, expanding on this topic of antifungal resistance, this is a growing concern and very problematic, as treatment is often prolonged, and even if after such a long course of treatment, in most of these cases, there is no clinical cure or response. So antifungal susceptibility testing is needed to rule out the resistance and to point the exact most appropriate therapy. However, in most of the cases, antifungal susceptibility cannot be performed in most setup, as there are many challenges in performing antifungal susceptibility in these fungi. First challenge is the slow rate of growth and fastidious nature. 7 to 14 days or 1 to 2 weeks are required to obtain the growth from the specimen. And once the growth is obtained, further subcultures are often required to obtain a pure growth because contaminants, bacterial or other fungal contaminants can distort the results. Second challenge is the inoculum standardization because only the fungal spores or conidia are taken for the susceptibility testing, and certain isolates do not produce abundant conidia. And mechanical disruption methods like vortexing with glass beads or filtration are often required to obtain a standardized inoculum. Third challenge is lack of standardized methods. The guidelines such as CLSI M38A2 and JUCAST, they have recently produced the documents. However, these documents are not dermatophyte specific and have not been universally adopted. Fourth challenge is the endpoint determination. For susceptibility testing, we look for the inhibition of growth. But for fungal isolates, there is often a trailing growth or partial inhibition, which necessitates reading visually as more than 80% of growth inhibition. So this is a subjective interpretation, and which can lead to a variation of result among different observers. Fifth challenge is the lack of clinical breakpoints. Even if we perform a susceptibility testing according to the recommended methodology, there is no precise clinical breakpoint to label the isolates as either resistant, sensitive, or intermediate. And lastly is the aspect of practicality. Due to these number of challenges and required, these susceptibility testing cannot be performed in routine clinical labs, and it is mostly done for research purposes as of now. So this is from my side. Any questions will be encouraged.